so I have nothing to declare other than say that I don't work in the pre-transplant clinic. What did I say? Oh, no. I mean, I don't work in the pre-transplant, and the topic is on transplant candidacy, but we do get questions periodically. All right, so over the next half an hour, I just want to review the recommendations for vaccination in patients who are going into transplantation or at least candidates for transplantation. I think some of the recommendations are not any different. Everything you guys talked about is actually very relevant in patients who are prepping for transplant because all these are TB patients. But I think more interesting is actually the optimal timing of the vaccination because all these patients will be on immunosuppression. So everything that I talk about GN is so relevant in that population, and we have to prep them in advance so we prepare them for transplant. And lastly, I want to go over some of the cases that's really challenges that I face when they cross over to me and we don't have the proper documentation or we haven't done the proper vaccination. Right. So why do we care? Because it's raining transplant these days. And when I first started in 2013, we locally maybe have about 110, 114 transplant kidneys. And last year we did over 180. So between 2016 to 2017, we actually increased by 25%. Increased by 25%, and thanks to the fentanyl overdose. We just don't do that. And you can see across the country, there's a steady decline. This is the core data. And you can see there's a steady incline of the number of transplants, about 15,000 of transplants as of 2016, and dialysis has also increased as well. So it's highly relevant. And in terms of the number of transplants, it's about 1,280, so 1,500 or so. Out of that, about 90% are the first transplant, about 10% retransplant. How long did these people stay on dialysis? They got to prep for vaccination. They actually varies a little bit across the country. So in Nova Scotia, they have the best rate. They stay about 1,000 days compared to Manitoba. Whoever's from Manitoba, it's over 2,000 days. But in Ontario and BC, we're pretty good. We average about 1,500. So we're looking about 50 months on dialysis on average before patients get a transplant. And that really means about, 4 years or so on dialysis. Obviously, it depends on the rate. So this is actually very interesting, right? Because so all these people, it's actually depending on the blood group type. So if they actually blood group B, they actually wait a long time. Probably not so in Quebec, because we tend to get all the blood group B kidneys from Quebec and Ontario. But in BC, that's the longest wait time with blood group B. The A people, generally, I have a guy who just went on the wait list less than a year because new kidney. So it's quite variable, but on average, so these patients stay on your dialysis unit, so it would be very helpful for us if the patient actually get all the proper vaccination beforehand, so they can get waitlisted. And currently, I should say currently, as of 2016, there are about 3,000 people on the waitlist. Okay, so this is BC data. We have about over 500 people waiting for kidney transplant, and vary to about 10 waiting for heart. So why do we need to vaccinate pre-transplant? So some of the discussion earlier is actually very interesting. Our patients, the number one cause of mortality and morbidity is really ear infection, and a lot of these infections are vaccine preventable because we give them immunosuppression. We deliberately turn down the immune system, so there's really effects in the T cell and B cell immunity, and the vaccines don't work as well. And we also have to avoid certain vaccines, the live vaccines. We are not allowed to give any more post-transplant. So the timing of the immunization is actually quite critical for them. There's always the concern that even with the new Shingrix that I talked about, there's always the concern that are we going to stimulate the immune system so much that we're going to cause a rejection, because you can actually cause allo immunity. Nothing has really panned out. They've done a lot of studies with the influenza vaccine, hasn't shown to increase the rejection rate, but it's always a concern. Even with the Shingrix, some of the discussion board around the new vaccine, there's there's a lot of hype about whether we should or should not be vaccinating post-transplantation, even though they're not live vaccines. So this is also something that you guys talk about. So we know our CKD patients are considered immunosuppressed. So when you vaccinate, really, the earlier the better, and there's some data to suggest that. So across the spectrum of CKD, we want to vaccinate as early as possible when they're healthier because they can mount the response better. The minute they hit the end stage, the immunity is lower, they don't mount the response as well. The minute they hit transplant, we throw all these anti-rejection medication on them, and it takes a while before the immunity actually kind of responds. We know for a fact that if they actually have antibodies before the transplant, they actually help to predict how they respond post-transplant. But the degree and the duration of that immunity actually is much reduced in the solid organ transplant because they will always need these anti-rejection medications. So I mentioned the timing is critical. So this is actually before the transplant. So inactivated vaccine, we want to avoid within 2 weeks because it takes about 2 weeks for the body to mount the response. So if you actually vaccinate somebody 2 weeks before they schedule for transplant, it's actually really dicey because the patient may not actually mount the response to whatever vaccine is used. Live vaccine, BC say within the 6 weeks, we don't allow live vaccines, but the data from the National Advisory Group and also BCDC say 4 weeks minimum, so 4 to 6 weeks. Now, if the patient's actually on immunosuppression, so some of the GN patients that we're talking about, I think that's been alluded to already, the recommendation is actually to wait at least 6 months after retux. And if the patient needs ATG for whatever reason, it really should be also 6 months, 3 to 6 months for sure. Some studies have actually shown that about 40% of the patients who've been on ATG only have about 50% response rate after 3 months. So that's why the 6 months work. And if the patients are on any other immunosuppression, technically you should wait 3 months. And what's considered heavy immunosuppression? Corticosteroids, anything greater than 20 milligrams per day for more than 2 weeks. Recommendation is to wait at least a month before you would consider vaccination. And retux I mentioned, and also undergoing active chemo, you should wait about 6 months. Everything else on the list there should wait a period of time. Right, so what's live and inactive? So live are your mom's measles, rubella, the varicella vaccine, any of the live, attenuated influenza, yellow fever, BCG, smallpox, oral polio, and oral typhoid. The inactive are the ones that on the right-hand side. So your tetanus, Hep A, B, the trivalent influenza, meningococcal, pneumococcal, rabies, inactivated polio vaccine, and typhoid. I should add the same question on this as well on the inactive side. So then, because of the live versus inactive, and there's certain live vaccines that we cannot give post-transplant. So those are your MMR, your the live varicella vaccine, and also the yellow fever. Everything else is actually still. I'll go into some of the information on the individual vaccines in a second. So can we actually screen and see what we really need to vaccinate for the patient? So it's actually routine practice that before the patient even get waitlisted, we actually have to check titer. So Hep A we actually don't do, but the liver group actually have to do. It's more for the high-risk patients that we screen for Hep A. Hep B is routine, MMR is absolute, and varicella also has some money. So this is a typical report that we get back. You probably can see from the back there. So you see the Hep B, and then it will give you the titer that Karen mentioned. So we're looking for greater than 10. And then the measles, mumps, rubella, so they will tell you whether it's reactive or not. And so anyone that's not reactive or protocol, then they should get the series, and then the varicella as well, whether it's reactive or not. And this is a typical letter that go out to either the family doctor or our very aggressive health unit. I've been told they're very aggressive. They chase after patients to make sure they go in, which is really nice. Then it actually took that out of the pre-transplant clinic to try to chase after patients. So these are kind of the lists that we pretty well list everyone. So everyone has to have all these kind of checked off. The only exception is these. I added the HPV on because I actually think it should be actually on it for eligible patients. It's not common right now that we actually ask for HPV, but everything else that has to be all checked off before the patient would be approved for transplant. Okay, so a little bit more information on the MMR. So I just want to go to a couple of cases that I encountered the last few years. Just related to MMR, it's actually very interesting. So this patient was one of the first patients when I transferred to transplant, and I started in September, and he got his transplant in October. So I remember him really well. Nice guy, 37-year-old, with two young kids, one's 2, the other one was 6 years old. And I remember telling him at the time, we don't allow people to travel until a year later. Those after a year, he can go anywhere, right? So he was planning this big trip with the kids to Disneyland over the spring break. And he called in February, because I don't know if you guys recall that outbreak that they had in all the theme parks. So he actually called and said, is he allowed to go? I said, oh no, right? So we actually took back his titer, and his measles titer was 167, and generally anything greater than 150 is considered reactive. But he was born in 1978, and at that time the recommendation is actually 1 dose of the MMR. And I had to call the transplant ID and say, okay, this guy is kind of borderline. Is he allowed to go? And I'll tell you the answer later. So this is the second same kind of age range. Older transplant, 2009. So one day I got a call and said, okay, I went to my GP's office, and there was actually a case of measles that was being reported to public health. And he got a phone call from public health and said, oh, you have to come in for your MMR vaccine. So this is a young guy who knows enough that he's not allowed MMR vaccine, and he has to call and say, what should I do? And I dig through all the history. I couldn't find any serology report on file. So unfortunately, both cases, we have to compromise a little bit. I'll go through the MMR. I'll tell you what happened to them. Okay, so high mortality and morbidity, and 1 in 20 cases can have pneumonia, they can have encephalitis, and subacute sclerosing, and installation. So really severe. Patients are considered immune if they were born before 1970. The vaccine came out in 1960s or so, and so anybody before them probably have contracted measles. Or if they have lab confirmed immunity, titer considered greater than 150, or if they have 2 vaccines, or 1 if they're born after 1970. But in the high-risk patients, though, they are supposed to get 2 doses or lab confirmed immunity. For patients who had 1 dose, they should technically, if they're going into transplant, they should get a 2nd dose. So then the poor guy who's canceled the Disneyland trip, highly advised him not to go, and I can't remember where he ended up going, not to the States anyway, because it was a big outbreak. And the other guy, because he actually got called 2 days after he was exposed, and the window to get immunoglobulin was 15 days to 72 hours, and we couldn't get the titer early enough, so we brought him in to get immunoglobulin. It was just unfortunate how it happened. So that's why I kind of highlight how important it is to vaccinate people, and also to ensure we have all the records in place. So we actually doing a project on that, just to make sure we have all the stuff in place. For that reason, there's a lot of issues if we don't have the proper documentation. So pre-transplant, then, what we actually do, as you can tell, we actually check serology. We would vaccinate them if they have on minimal immunosuppression, and make sure it's at least 4 weeks, but our guideline is at least 6 weeks before the transplant. And if they are after 1 dose, if they still didn't convert, then we give them a 2nd dose. All right, varicella. So also very common, especially the zoster. Herpes zoster is very common in our setting. So generally, pre-transplant, kind of the same thing. We check for serology, we vaccinate if we can, and make sure they get the serology testing confirmation again. And generally it's 2 doses, and this is the chickenpox vaccine, so there are people who haven't been exposed to chickenpox. And I've actually seen a few cases of patients who actually had chickenpox before, but post-transplant they got chickenpox again. So it's actually more common than we appreciate. So this is another case that we had not too long ago. So a 77-year-old retired pharmacist who asked very good questions, but unfortunately got very confused, ataxic, and got a rash around the eye and non-reactive pupil. Transplanted just 10 months ago. They had to do a lumbar puncture, and they actually found the zoster virus in the CSF, and he got encephalitis. So serology, he was positive for varicella, but we don't routinely vaccinate people for the shingles, and so he never got the shingle vaccine. So that's what happened. I've seen disseminated zoster, I've seen pancreatitis because of herpes zoster. It's actually could be very traumatic, and usually if you don't catch it early enough, they have really severe post-herpetic neuralgia. And we have probably more than 10 cases a year. We have a population of more than 950 post-transplantation in our clinic, so it's not uncommon. Okay, so zoster, herpes zoster is caused by the reactivation, as you know, of the varicella zoster virus usually along the dermatome, but as I said, I think this in the cases, just because our patients are so immunosuppressed, can occur up to 20% of our transplant recipients, but it's not that high in the population, but still it's been reported to that. Generally, the vaccine is recommended if patients been exposed to varicella, so that if they had chickenpox, if they're more than 50, but unfortunately in our province it's not funded, so a lot of patients have not received it. We don't really know if you actually give the vaccine, how they respond post. But generally, if people ask me, I probably would tell them, having seen the traumatic cases that I have, I usually would ask them to vaccinate beforehand. But if they have a previous episode of shingles, they're supposed to wait a year. So the guy who actually got the encephalitis is in a year now, and I just recently asked him to get the shingles. So Softavax, as somebody alluded to, is a live vaccine. You can use it in the candidate before the transplant, but contraindicated in the recipient because it's a live vaccine. So Shingrix just came out in January. I kind of mentioned the data is not great out there yet. I've recently seen an abstract that was presented in one of the transplant conference, and it involved about 150 patients or so. Did not show any increase in alloimmunity, which is encouraging, and also similar rejection rates. So it's looking promising in our population for sure, but it's pretty pricey. It's not funded by the government. So Hep A, I kind of mentioned, we don't routinely check for serology, but in the liver transplant population, they would, and also any high-risk exposure, such as travel, occupation, or lifestyle. Seroconversion rate is not great. Hep B, I think Karen did a really good job. I won't belabor the point, but we do everything that you guys do in CKD population. We just haven't been very good in checking serology post, and this is one of the projects that we have to do. And I think even though our patients may not be exposed to blood anymore, but you never know when the transplant may fail. Same with what you guys were talking about, maybe they need to cross over to different modality later. So it's really important that we actually continue to vaccinate these patients. Pneumococcal is actually high risk in our patient. I saw 2 cases just the last fall. It just tends to become a raw infection, including pneumococcal. The 2 vaccines out there are the conjugate and the polysaccharide. So the difference is the conjugate has a protein that helps to stimulate T cell and B cell. They have one serotype strain, the 6A, that's not found in the polysaccharide 23. Polysaccharide actually has 23 strains, so it actually covers more of the pneumococcal strain, and we need the years. Both are inactivated. Now, there's some suggestion that if you prime with the conjugate, so that's the Prevnar 13, and then give the polysaccharide, Pneumovax, 8 weeks later, you can actually enhance the immune response response to pneumococcal. It's been shown in like other immunocompromised patients like the stem cells and such population. Hasn't been quite shown or panned out in the solid organ transplant. It's not the Proteinol 13 is not funded in disease. The sequence and the timing is actually quite important, and just because we polysaccharide antigens, the more you do, apparently you actually become more hypo-responsive. So the timing is very important. So the recommendation is if you never had the polysaccharide, so you never had the pneumovac before, we would ideally start with the conjugate, so the Proteinol 13, and then you follow by the polysaccharide 8 weeks later. If the patient had the pneumovac, like a lot of our dialysis patients have the pneumovac vaccine already, then you have to wait at least a year before you give the conjugate. And this is just another schematic of what it meant. So you have the 13, you have to wait at least 8 weeks before you will give the 23, the pneumovac, and you have to wait 5 years before you give the second dose. So there's some suggestions that you can actually give a third dose, but in transplant, the 2 doses is all that's recommended. And then if you start with the 23, the pneumovac, you have to wait at least a year before you can give the 13. And then this whole thing, until the next dose of the 23, that takes 5 years. So influenza, we push influenza vaccination to almost everyone because our patients actually land in the hospital more commonly than not with the influenza whenever there's an influenza outbreak. So protection rate done in this study is actually pretty high, but most of the studies really only about 60%. There's no benefit shown in the study to boosters. Sometimes when you actually give the vaccine early, during the tail end of the vaccine, the influenza season, people will start getting the influenza. This study actually showing no benefit to boost. And they also show no increased rejection, which can be validated in a number of studies as well. So the interesting thing with the influenza is, so it's the timing of your transplant. So a lot of patients, if they're lucky, they get the vaccine first, and then they get transplanted within, a month later. So they're somewhat protected. But there are patients who just never quite made it to get the influenza vaccine. And if they get transplanted in October, November, what do you do with that population, right? So generally we tell them, you should probably wait at least a month. The recommendation varies so much depending on the guidelines. KDIGO actually say you have to wait at least a month. AST say 2 to 3 months, and then IDSA say 2 to 3 months, AST say 3 months. So everyone's all over the map. I think it's the risk-benefit ratio. If you have an outbreak of influenza, vaccinate them. There's no harm. But it probably won't work. So an activated vaccine is what obviously we use, the trivalent one with the influenza A and B and the H1N1. And you can use it in both the candidates and the recipients. The live vaccine we cannot use. The HPV is interesting. There's actually increased risk of anal genital cancer, skin cancer for sure, and what's in our population. So I actually am a believer that maybe in our population we should use promote HPV vaccine. Unfortunately, again, it's a funding issue. It's only eligible for funded in BC anyway for women who were born after 1994. So you're looking at your 24-year-old and younger and or high-risk individuals. So so HIV patients or MSM or patients who may not be in custody. Anybody who could be eligible are younger than 45 years old, but they're not funded, so it becomes a cost issue for a lot of patients. But given the risk that you have post-transplant, the number of cancer that we see, I think it's actually worthwhile. So this is just a summary of all the vaccines that I kind of mentioned. I won't kind of review them in detail, but they kind of break down to who you would actually vaccinate, what's the dosing recommendation, and some of the caveat in terms of 40 micrograms per dose in our population. And in summary, I hope I convinced you that it's very important to vaccinate. In fact, your patient won't get transplanted anyway if they don't. But it's also equally important, I think, in our setting, that we keep up the job to make sure we keep up with the vaccine status, continue vaccinating patients. The timing is very critical because if we miss the boat in pre-transplant, then it's become a lot more challenging post-transplant to vaccinate a lot of these patients because they don't have the same response anymore. And we have to avoid live vaccines. We have to avoid them at least 4 weeks before the transplant. And when we induce them and give them a lot of heavy immunosuppression, we have to wait 3 to 6 months before we can actually give them the vaccine. Otherwise, it won't work. Question?